Hello and welcome to 2-Minute Anaesthesia in Critical Care. Today we're going to discuss intra-aortic balloon pumps with reference to definition, setup, physiology, placement, weaning and complications. Kantrowitz first described augmentation of coronary blood flow in animal models in 1952. Nevertheless, the aortic balloon pump was first introduced in the 1960s with the aim to support coronary and systemic circulation. The cardiac support device is achieved by synchronous counterpulsation, whereby an intra-aortic balloon inflates during diastole and deflates during systole, with an aim to increase myocardial function by increasing myocardial oxygen supply and reducing myocardial oxygen demand. The indications for placement of an intra-aortic balloon pump can be split up into two subgroups: those which can result in cardiogenic shock, for example acute MI and mechanical complications, acute congestive heart failure and post-op cardiac surgery. In addition to those which require a bridge to treatment, for example intractable angina, myocardial ischemia, heart failure or ventricular arrhythmias. Contraindications can be absolute, i.e. due to severe aortic regurg, aortic disease involving stents and dissection, and also end-stage cardiac disease. Relative include uncontrolled sepsis, bleeding, AAAs and PVD in severe forms. The balloon pump device has two main components. Firstly, a double lumen 8 to 9.5 French catheter with a 25 to 50 mm polyethylene balloon attached to the distal end. Helium is used to inflate the balloon, as its low density means its little turbulent flow, resulting in rapid inflation. And secondly, a device with a pump. Now let's discuss the physiological effects of intra-aortic balloon pumps. The balloon inflates during diastole, resulting in a volume displacement of blood within the aorta, both proximally, which increases aortic root diastolic pressure, resulting in an increase in coronary blood flow, and distally to increase systemic blood flow. The balloon pump will deflate in systole. This reduction in afterload was achieved during the diastolic phase, whereby the balloon is inflated, resulting in blood displacement from the aorta, therefore reducing the force required to eject blood from the ventricle during systole. This results in a decrease in both LV workload and myocardial oxygen consumption, ultimately resulting in improved myocardial oxygen to supply to demand requirements. A summary of the hemodynamic effects are shown below. Those of the heart to increase cardiac output, reduce afterload and preload; of the LV to reduce systolic blood pressure, reduces end diastolic blood pressure, reduces volume and therefore wall tension; and finally the effect on the vessels, resulting in a reduction in systolic blood pressure and an increase in diastolic blood pressure, which therefore increases perfusion of the coronary vessels. Now let's discuss the aortic pressure waveform. We'll start with the left side with the unassisted end diastolic pressure. Then you have the systolic upstroke to the unassisted systolic pressure. Then we have a decline in the pressure followed by a diastolic augmentation of the balloon pump. This results in a lower end diastolic pressure termed assisted diastolic pressure and associated lower systolic pressure, i.e. assisted systolic pressure. Abnormal activation of the intra-aortic balloon pump can result in an altered curve, which will be discussed at a later point. Insertion of a balloon pump is usually achieved by a Seldinger technique, usually into the femoral artery, and following this requires systemic anticoagulation. To confirm placement of the balloon pump, this can be achieved via a chest X-ray, fluoroscopy or TOE. The tip should be 2 cm distal to the left subclavian, or which is the second rib, and proximal to the renal arteries. This chest X-ray highlights the position of the balloon pump. The proximal balloon tip must be distal to the takeoff of the left subclavian artery, and the distal balloon must be proximal to the takeoff of the renal arteries. On this chest X-ray, if the radio-opaque tip is seen overlying the AP window, i.e. the aortic pulmonary window, the balloon pump is assumed to be in the correct position. If this does not lie within this window, you may consider malposition. Now let's set up the balloon pump. This involves a trigger. This trigger in regards to balloon pump inflation could be based on ECG, the pressure, an internal trigger. For example, if the patient is asystolic in a cardiac arrest, the balloon pump will automatically inflate, and also pacing devices. And the augmentation frequency, i.e. the number of augmented beats per cardiac cycle. This could be 1 to 1, so every beat is augmented, or it could be 1 to 2 or 1 to 3. The patient's ECG is generally the most reliable option with reference to the trigger. The intra-aortic balloon pump identifies the middle of the T wave or the dichrotic notch on the RTA waveform corresponding to diastole, and this triggers inflation. Conversely, the R wave and the ECG are just before the systolic upstroke, corresponds to the opening of the AV valve, relating to the onset of systole and thus triggering deflation of the balloon pump. Inflation of the balloon pump too early or late will affect the arterial waveform. Too early, you can see there's a peak before the dichrotic notch, and too late, it's after the dichrotic notch. The size of the effect of the intra-aortic balloon pump relates to three main factors: balloon volume, i.e. blood displaced is proportional to the volume of the balloon. More blood is displaced with a larger balloon volume. The heart rate. The LV filling times are inversely proportional to the heart rate, i.e. a shorter diastolic time produces a lower augmentation per unit time. And finally, the aortic compliance. As the aortic compliance decreases or SVR increases, the magnitude of the diastolic augmentation also increases. Improved performance is seen in patients with a sinus rhythm, a heart rate less than 120 beats per minute, a correctly placed catheter and balloon volume, and an appropriate assist ratio. Successful weaning from a balloon pump requires management of the underlying etiology relating to the cardiogenic shock with adequate blood pressure control in the absence or minimal inotropic support. This could be achieved in different ways, for example, reducing the augmentation frequency every 1 to 6 hours, for example from a 1 to 1, so every beat's augmented to 1 to 2. A ratio of 1 to 3 should be avoided over a prolonged period of time due to the risk of thrombosis. Now let's discuss complications. The benchmark registry reports an incidence of 2.6% for major complications, for example, limb ischemia or severe bleeding, and only 0.05% of in-hospital mortality was directly attributed to balloon pumps. The complications can be split into three main groups: those due to general, for example, infection, bleeding, or anticoagulation related, for example, from HIT with the use of heparin; vascular related, due to the insertion or removal of the device, which can result in dissection, perforation, aneurysm formation, hematoma, AV fistula, and also entrapment; and finally balloon related, due to malposition, which can result in acute kidney injury, CVA, acute liver injury, spinal cord, and limb and mesenteric ischemia. Rupture of that balloon can result in gas embolus, and also the use of balloons can result in hemolytic anemias and also thrombocytopenia. Once again, thank you for listening.